All right, everybody. So we're now going to talk about management, and we'll basically touch upon surgeries, radiation therapy, and chemotherapies. When it comes to cancer, those tend to be the main ways that we try to treat it. So for surgery, so the goal for surgery is to remove the entire tumor or as much as is feasible, and that could be known as debulking. That's a terminology that they can use when they're trying to take out as much of the tumor as is feasible. The primary method of treatment is surgery for a lot of cancers, unless it's a type of cancer that they can't reach. So if the cancer or the tumor is in a place where they can't get to, then they're not going to be able to take it out. So then they have to kind of think about other ways that they can treat the patient. So many different reasons why you can do surgery. So obviously to take out the tumor, it could be done prophylactically, like like we talked about, people that have the BRCA1 or BRCA2 genes, so they don't necessarily have cancer yet, but they've decided to opt to take the breast out as a prophylaxis, right? To potentially help them from not getting the breast cancer. It could be palliative. So these are some of the patients that are basically just to decrease some of the signs and symptoms that they're getting, to minimize, the very aggressive manifestations that can happen from cancer. Or it could be reconstructive, right? So maybe patients have had breast cancer. They've taken out the tumor, but now they're doing reconstructive surgery specifically just to give the patient a breast that's not really a real breast, but like the tissue is being reconstructed, like they're using tissue, whether it's from the thigh or something, but they're using that tissue to create the illusion that the patient has their own natural breast, right? So several different types of surgeries. So we've mentioned that some of them are prophylactic, some of them are palliative to decrease some of the signs and symptoms that they're getting. Some of it could be reconstructive. So all of that is possible. They can do diagnostic surgery, and we've described the different types of surgeries under this category. So those are the biopsies that we talked about, right? And in that case, we're using it for diagnostic purposes. So we mentioned that sometimes it could be excisional, so it's just local excisional, it's radical, right? So all of these fall under surgeries. So here now is where we're talking a little bit more about what the difference is between local excision versus radical. So local ideally is under an outpatient basis. They're removing the mass and the small amount of the surrounding tissue, right? For the radical, that's known as a wide excision. So they're trying to get to the primary tumor. They're trying to take out the lymph nodes. They're trying to get rid of the adjacent involved structures. And the reason we're doing all of that is because all of that surrounding tissue is considered high risk for metastases, right? So this is excisional. So when it comes to prophylactic surgery, we're basically trying to look at reasons as to why we want to perform the surgery in a prophylactic manner. So in other words, let's perform the surgery so that the patient basically doesn't end up developing cancer, right? So if we think the patient has an increased risk of developing cancer, we put prophylactic surgery on the table. So specifically, we've mentioned the BRCA1 or the BRCA2 gene. And as I mentioned previously, everybody has BRCA1 gene and a BRCA2 gene. And apparently, normally, these proteins, they identify and repair damaged DNA in the cells. So if there's any damaged DNA in your cells, they'll go over there and they repair it. Unfortunately, what happens is that sometimes those genes get mutated or they become altered, and then they no longer function properly. So basically, the damaged DNA that's in your cells basically doesn't become repaired. All right. So the story is that well, it's not a story, but the explanation is that if you are a child of a parent who carries a mutation in either a BRCA1 or BRCA2 gene, um, then you have like a 50% chance of actually inheriting the mutation. And then that puts you at an increased risk category to possibly developing breast cancer. All right, so this is just important, and you don't have to memorize that, but this is just important to know in terms of your health screening when you're talking with your patients, because then this information becomes important, right? So you're going to look at the patient's family history, you're going to look at the patient's personal history. Maybe they do have a family of breast cancer, but maybe they're very fit, they're healthy, they eat well, and they don't necessarily want to maybe get a prophylactic mastectomy, let's say. So you want to factor in all of those, because at the end of the day, the patient is still the one that makes the decision as to whether or not they want to get the prophylactic surgery. So you're also going to look to see whether or not the patient has any presence or absence of signs and symptoms. Is there any risks that are really, really great at this moment? And are there any benefits to them actually getting the prophylactic surgery? And depending on, when you catch the cancer, right, as we mentioned before, you want to detect this early, early, early. But depending on when you catch the cancer, does it make sense to even have the surgery? Is that really going to prevent the cancer from metastasizing, right? So you really just want to look at your patient in a very holistic manner and look at the risk factors and look at, the post-operative outcome and whether or not this is something that will be very beneficial for your patient. There is what is known as palliative surgery. So primarily this is to decrease the amount of symptoms that you're getting, just to improve your quality of life, right? So you want to relieve the symptoms and you want to improve the quality of life. And this could even be like for patients that are in hospice sometimes, right? So maybe you have abdominal cancer, so maybe they'll put it in an abdominal shunt just to basically help with the surgery. Maybe they need to put in a biliary stent placement, or maybe they need to put in a colostomy or an ileostomy because you have colon cancer, let's say, right? So these would be considered palliative types of surgeries. And reconstructive surgeries, I've already mentioned, so this could be for breast, head and neck, or skin cancer types. All right, so they may be doing reconstructive surgeries here. So your nursing management in terms of a patient going to surgery, so it's pretty general. So peri-operative nursing care, general, making sure that the patient knows what's going to be happening, talking about the types of treatments that are the patient should expect. You are usually just reinforcing whatever the surgeons have told the patient. If your patient says to you, I have no idea what you're talking about, I didn't even know I was having surgery, well, everything has to stop, everything has to pause. You have to call that surgeon back to speak to the patient. It is not your responsibility to make sure the patient understands what type of surgery they're going to have or what is going to happen after the fact. Ideally, the surgeon, anesthesiologist, all those people have spoken to the patient and told them what the different complications are, what to expect. All of that has already been done, and then you're essentially just reinforcing some of that teaching. And a lot of times you're probably dealing with the fact that the patient is anxious, they're scared, they're depressed. So a lot of what you're going to be doing is maybe psychological, like before they actually have the surgery. There'll be a lot of crying, a lot of hand holding that will be going on. For the preoperative nursing care, so information about the surgical procedure itself, what the dye is going to look like, bowel preparation, prophylactic antibiotic therapy, issues of anxiety, about outcomes, findings, prognosis, body image. All of that needs to be discussed. So they're using the word perioperative kind of including, I guess, all the different stages, like you're doing pre and post types of teaching under perioperative. So the information is general, but it's including all the information that the patient needs to know that has to do with complications. And complications obviously are not going to happen until they're in the post-op period, right? You've had the surgery and now you're in the post-op period. So perioperative is including all of that information. So you're including the the pre-operative information as well as some of the post-operative information, just really making sure the patient knows everything related to this surgery. And peri can kind of mean round, so it just basically means you've covered all the bases. So round, like you've given them all the information that they need. So for pre-op, making sure there's consent, you as a nurse making sure you're giving any antibiotic therapy if it's needed. Like I mentioned, you can be dealing with a lot of stuff about body image. You need to be knowledgeable about the diagnostic procedures, right? So you need to be able to reinforce teaching that's been done. Like if your patient says to me, okay, my doctor says I'm going to need to have an excisional biopsy done before I have my surgery because they really want to get a sense of how bad my cancer is or something like that. And then they say, but they were talking about whether it's radical versus local, and I don't know what that means, right? I mean, you can safely say, well, radical is there's more cutting that happens versus local, there's not that much cutting that happens. So little things like that you have to be able to understand. Post-op, so you're looking at the patient's response to surgery. You're monitoring the patient for complications. So that includes things like PE, pulmonary embolism, and by now you guys know what the signs and symptoms are of PE. Looking for bleeding, wound dehiscence, right? Patients saying crazy things like, ooh, I feel like something popped. Wait, hold up. Okay, sit down right here, and you're not moving anymore. Let's see what's going on, right? And wound dehiscence for sure. A doctor needs to be called, right? You're going to assess what you see, and then you're going to call the doctor. If the family member is with the patient, and then the family member comes running to you and they say, my niece just said something popped, you're not going to run to the phone right away to call the doctor. You're still going to go to validate the information, assess the patient quickly, and then you're going to call the doctor. So all those types of different critical thinking skills are required. You're providing for comfort, for sure, medication for pain, for sure. And then under discharging, you're giving them all the teaching that they need for home care and any type of treatment that they may be needing afterwards. So a pretty big number of cancer patients receive radiation therapy at some point in their treatment, right? So it can be used, the radiation, as a cure in certain types of cancers like thyroid carcinomas, head and neck cancers, cervical cancers, right? Perfectly works in some cases. It can be used to control or reduce the tumor size. So that's the goal for those types of cancers. It can be used as a palliative radiation to decrease some of your symptoms and manifestations to make the patient feel better. Or it can be an adjuvant therapy. So it could be in addition to maybe the fact that the patient had surgery, they've taken out as much of the tumor as they possibly could, but they're like, you know what, we're worried that we left some stuff back, let's also add radiation. So there it's being added on, so as an adjuvant therapy. So I added this slide because the slides after the previous slide are okay, but I just wanted to kind of unpack the information a little bit better for you so that you could at least get a better sense of the different ways that they can give radiation. So there are many different ways to give radiation, and they can describe it in a lot of different ways. So hopefully this chart will be helpful. So we're in the first column first. So radiation can be given externally, and an example of that would be what they call an external beam. They'll call it external beam radiation therapy, and the example would be a gamma knife. And I think there's a picture in this slides. Radiation can also be given internally, and the internal type of radiation can be given in the form of a solid, or it can be in the form of a liquid, right? So this is just, so don't overthink any of this information on here. Look at it, try to understand it as best as you can, because there are different ways that people talk about radiation, and you won't know if they're necessarily talking about external radiation or internal radiation, or if they're talking about the fact that it's a solid or if it's a liquid. But I just want to give you this overview. They can say that the radiation is being given in a systemic way, right? It's a systemic type of radiation, and they may say that they may give it PO, they may give it IV, or they can give it as an injection. So remember, we already said radiation can be given in the form as a solid, or it can be given as a liquid. So obviously, if they're giving it in a liquid form, then that becomes more of a systemic type of radiation because it's a liquid, right? It's PO, it's IV, or it's being injected in some way. So the signs and symptoms that you're going to get from that are going to be also much more, maybe potentially more severe, because if it's systemic, it's going to travel throughout your body. So some of your signs and symptoms are going to be maybe a little bit worse. And also that matters now because if it's systemic, that means it's in your system, it's traveling out, and potentially you're going to poop it out, or it's going to come out in your urine. So now it matters in terms of how we are discarding all the linen that the patient is using, right? If they're getting a systemic type of radiation, now it matters how we're discarding the linen that the patient is using. It can be described as solid, which we mentioned earlier, and they may call that brachytherapy, right? So it can be described as solid, and they may call that brachytherapy. And they're able to give this type of radiation in the form of seeds, their ribbons, their capsules, and these things have radiation in them. And these seeds, ribbons, or capsules basically are placed near the tumor itself, right? They're placed in the body and they're near a tumor, right? So, and then it gets even more complicated after that. But just be able to look at this carefully and know that there's different ways that they can give radiation and there's different ways that they can describe it. All right. Perfect. So we said it can be external and we said that it can be internal. So for the internal types of radiations, so under internal, I've decided to basically break it into two. So we already mentioned the fact that the brachytherapy is the one that they can put inside your body, right? They can put it in next to tumor. So now we're specifically looking at brachytherapy. So this is within or next to cancer site. It's implanted by rods, seeds, beads, ribbons, catheters. They can put this in the vagina, the abdomen, the prostate, the breast tissue, right? They can describe this type of brachytherapy as either being sealed or unsealed, right? So sealed just means it's basically wrapped up nicely. It's going to basically just stay in that one particular area, or it's unsealed. So therefore, there's potential for that radiation that they're given for it to basically travel within your body, or just kind of have some type of systemic type of manifestations in terms of output, that you might be able to secrete that as well, right? And so it may show up in how you are getting rid of the your linen, let's say, right? So it can be sealed, where it's potentially just sealed to one area, it just sits there, or it's unsealed and has the potential to basically travel through your system in some way. So, and I just want you to be aware of these terminologies because they're kind of weird when you're doing questions. I want you to pay attention to, because then it matters, like in terms of what are the nursing implications, like what is it that we have to do, all right? So for the brachytherapy, they can also describe it as being temporary. So in that case, they usually do high dose, and they usually give it for a very short time. And once again, this brachytherapy can be given via needles, catheters, rods, and then they take them out. Ideally, they say it can stay in your body for a few minutes to a few days, right? So we're dealing with brachytherapy. We're still under internal types of radiation. If they're calling it permanent, still being given via those tiny seeds, whatever, they're implanted. Some of those seeds can actually exit the body, right? But you need special precautions to protect from exposure, right? So that special precaution is just talking to the fact that you need to deal with the linen in a very special way, okay? And I'll talk about the other precautions on the next couple of slides. Ideally, when they give you these permanent types of radiations. It's usually low dosage. They say that over time, the seeds can lose their radioactivity. And that at some point they may even become inactive, and they just leave them in the body, so it doesn't really matter, right, at the end of the day. But the idea is they give it to you in a low dose. It stays in the body for a long time, and it becomes less radioactive, and then it basically just becomes inactive. But the idea is that they've treated the cancer that they were trying to treat. All right. So there's different ways to give this type of internal radiation, and that's really just the main takeaway. Remember, under internal, we also said that could be a systemic type of radiation. So for this one, they're giving you radionuclides, and these can be given either PO, IV, or injection. I've given you a couple of examples here. So examples of IV administration of radioactive isotope, and these are targeted to a specific tumor. So one example is radioactive iodine, I-131. So this is an example of a systemic brachytherapy. So the reason why it is internal is because it is inside. So that's why they're using that word here potentially for brachytherapy. But we're also describing it as systemic because it's an IV. So it's going to go throughout your system, throughout your body, right? So this is radioactive iodine, I-131, and they use this one for thyroid cancer, right? There's also another example, radiation 223 chloride, and this can be given for prostate bone metastases. All right, so don't get crazy, don't get overwhelmed by this. There's just so many different ways that they can give radiation. I just want you to kind of have a sense of what they mean when they're saying, like if they're calling something brachytherapy, or if they're calling it external beam therapy, that you have a sense of what it is that they're getting at. All right, so now specifically we're looking at our external beam radiation therapy. So for the external beam radiation therapy, you have particular markings, and then they're going to beam the radiation onto you. So in terms of your nursing manifestations, what do we care about? Well, what are you going to teach your patient, right? What is important for them to know? So what must they know? So you're going to make sure that they know, do not remove the skin markings. They're getting radiation. So remember, radiation is targeting cells that are proliferating quickly. What are your side effects going to look like? So pretty similar to actually chemotherapy types of side effects. So myelosuppression, infection, bleeding, fatigue. So even though the radiation that was being given to you was not necessarily a type of radiation that's considered systemic, that's considered PO, IV, or an injection, because here we're talking about external beam radiation, still the manifestations or the side effects that you're going to get are going to be systemic. So that systemic effect from radiation is always there, right? It's always a true statement. So you can get GI complications like nausea, vomiting, anorexia, diarrhea, mucositis, and even fistulas, which are abnormal connections that are happening now in your body, right? But the main takeaway for external radiation is the fact that you should not be removing those skin markings that are there. All right, and because it's external, there's also the skin excoriation that can happen. Skin excoriation is no fun. It hurts. All right, so here you go. This is an example of the skin excoriations that can happen. So you can get things like dry desquamation, or you can get wet desquamation. We hate wet, and we hate both of them, but wet desquamation is even worse because now you have a potential there to get infections, right? Your skin integrity is impaired for sure, and this is really bad. It's definitely not a risk here. It's an impaired skin integrity. So do not wash off the markings. The skin excoriation can be very painful. So you want to have cool, very light dressings, or like light compresses that you're going to apply to that area to kind of help it heal. I mean, ideally you kind of want it to be open to air so it can kind of get all the oxygen that it needs. Ideally you just want it to be getting perfusion, right? I've found that sometimes if you get a cut, right, you leave it open, just make sure it's clean, it's intact, and it's dry, but you leave it open to air, it heals faster than if you cover it up in some cases. So all of that anyway, if it's a cancer unit, you have specialists that are specifically going to help you teach the patient how to best take care of this wound that they're going to end up with. So you can give things like NSAIDs for any pain. The excoriations can be itchy. You can wash them with mild lanolin-based creams to help with itching. So wash with mild lanolin-based cream to help with itching. You're not using things, that are not approved, because then they become mediums for infection or they can aggravate the situation, right? This is not some place where you're going to be giving like alcohol, let's say, because alcohol is not going to help the situation. So we worry about the fact that they can have an infection specifically for the wet excoriations. All right, so this could be an example of an external beam radiation. Okay, the external and the internal radiation implants. So I've discussed these earlier on the previous slide. So remember that they can be called Reiki therapy. And remember, there's also another category for internal radiation that's known as systemic. And for that one, it's the PO, IV, and the injections. All right. So here we're talking about the brachytherapy. So it's delivering radiation to a localized area, and they do different ways to give you this radiation. So it's via rods, seeds, or beads. So it can be temporary. Usually it's a high dose, so it's permanent, which is considered a low dose. Some of your safety precautions when your patient is getting brachytherapy. So private room with a sign, bed rest to prevent dislodgement of the implant. You're limiting visitors. You're rotating the nurse assignments, and the nurse has to wear what is known as a dosimeter. So you're rotating the nurse assignments so that not one nurse is always getting that patient with that radiation implant, right? Because as a nurse, you're also getting exposed to that radiation. So that's why you're rotating the nursing assignment. So this is also an important concept to understand, because normally in the general nursing world, regular floor, med-surg floor, ideally, when you're making the assignment, you are giving the nurse that had the same patients the night before. You're giving them the same patients, because that helps with continuity of care. That helps when the nurse is doing an assessment. They can see if something has changed, right? So that's usually why nurses are fighting for the same assignment that they had, because they know the patients. They have a history. They've done an assessment already. So if something goes wrong or something changes, they're able to identify it. But when we start having patients that are really, really sick, let's say they're on vents, they're critical, they have cancer, it's not fair to give that nurse the same patients over and over again, because now that nurse's level of stress is increased, that nurse's level of being exposed to radiation is increased. So then the thinking in terms of patient assignment has to change, right? And this is where you nurses, you guys, once you become nurses, you have to become advocates for yourself, because sometimes you're a new nurse, they're going to keep giving you the vented patient, the more sick patients, and they're going to keep telling you, oh, you need to learn. No. I can learn just fine if you rotate this patient. I don't need to be getting this patient every single day. So you kind of have to balance the learning versus you getting worn out and you getting sick as well. All right. So you're rotating the nurse assignment. The dosimeter, it measures how much exposure to radiation you have. So you are not sharing that dosimeter with other nurses. It is your dosimeter, and it measures how much radiation you're getting exposed to, so that they can know whether or not you're getting high levels of radiation, and maybe you don't need to be on that floor for a minute. You need a break for a little bit, right? There are concepts of time, distance, and shielding. So in general, they don't want you spending more than 30 minutes in that room at a time. Like if you're staying in that room for 30 minutes or longer, that's a problem. I mean, patients that have cancer, yes, some of them are really, really sick. They're complicated. They might be sick. They might have other illnesses. They may be on a vent. They may need to be washed. Like just a whole bunch of different things going on. So you're going to spend time in the patient's room. And what they recommend is you go in and you do what you can, or do as much as you can. And obviously, but you want to give the patient rest. You leave and then you come back again. But they don't want you going in and out so many times that you keep exposing yourself. If you have to do something in the room, do it, get it done. Sometimes your patients might say no as well. So, like, you just have to balance everything. But in general, you don't want to be in there more than 30 minutes at a time. You specifically, if you have like family members, right, that are coming to visit, this is where this rule even becomes even more stringent. You don't want them really close. They want you to be at least like 6 feet away. Six, the number six, SIX. They want you to be at least 6 feet away. And there may be variations in how all of this works in different institutions. But obviously, if you're a nurse, you have to watch the patient. If you're a nursing assistant, you have to watch the patient. You can't watch the patient from 6 feet away. You have to get close. But you're keeping track of how much time you're spending in the room. And then the other concept is shielding. So the nurses wear lead aprons, and those are supposed to basically shield you from the radiation, right? And then you are worried about the bodily excretions, especially if the radioactive source that they've put in is unsealed, right? Because now potentially that radioactive component, whatever it is, has the potential to basically just spread with throughout your whole body. So now your bodily secretions matter. And so how are we going to be getting rid of this linen? And how do we deal with all of that? If they have, let's say, this is just one example, if they have like a seed implant, it's implanted, it's sealed off, and it's a low dose, let's say, so then that patient is going to go home with that. The radiation exposure is considered to be minimal. And remember, we already mentioned that some of these, they become inactive after a certain time, etc. So you just have to know specifically what type of radiation my patient has, right? Is it external? Is it internal? And what are the precautions that I need to worry about, right? So it's important that you know what type of radiation therapy your patient is getting. So you worry about toxicity. So you worry about the area that's being radiated, right? How all of that is looking. If in addition to radiation your patient is also getting things like chemotherapy, obviously toxicity becomes even more so now, right? You're looking at your skin, you're monitoring for alopecia, especially if the brain is being radiated. But remember, some of your systemic manifestations are going to be present regardless of whether or not your brain is being radiated or not, right? You worry about things like oral mucositis, stomatitis, bone marrow depression. That goes without saying for a patient that's getting radiation. All right, under chemotherapy now, we are talking about anti-neoplastic drugs that are basically trying to destroy cancer cells by interfering with the cellular functions. So they interfere with the different stages of cell function. So it could either be replication, DNA repair, all of that, right? So the different medications, and each of them can be targeting different parts of the cell functions of the cancer cells, right? So you're treating in chemotherapy. So this is, you're getting chemo. So it's going to be systemic for sure. It's not localized, right? Because you're getting this most likely via the IV, right? So what are some of the goals for this? So we're trying to decrease the tumor size. So you can get chemo pre-op. So before maybe they have surgery even, maybe they give you some chemo, right, to decrease the tumor size to see if that works. Or maybe the tumor is too big, right? So they want to decrease the tumor size before they actually go in and they take it out. Because some tumors are way too big and they can't do anything about it. Or they're giving you chemotherapy post-op. So maybe you've had surgery, they've taken out as much of the the tumor as they could, but then there's still some left. So now they're giving you chemotherapy post-op, right, to destroy the remaining tumor cells. In some cases, they're giving you chemotherapy specifically to treat a particular type of cancer where it's been shown to be very, very helpful. So maybe leukemia or lymphoma forms, they're giving the chemotherapy as a primary means of treatments, right? So the goal determines the medication used and the aggressiveness of the treatment plan. So each time a tumor is exposed to a chemotherapeutic agent, 20 to 90% of tumor cells are destroyed. But that specifically depends on the dosage, right? Eradication of 100% of the tumor is almost always impossible. The goal is to eradicate enough so the remaining tumor cells can be destroyed by the body's immune system. All right, so we've talked about this part on another slide when we talked about the different phases of chemotherapy. So we talked about induction, what was it? Induction, there's another stage, and then there is maintenance. My brain is not working right now, but you know the phases, okay? All right, so this is just an example of some of the anti-neoplastic medications that can be given to the patient. So once again, you're worried about the ones that have made it on your list. All right, so different ways for you to be getting this chemotherapy. So oral, IVIM, subcu, intrathecal, arterial. IV chemotherapy, though, needs to be via a central line. And the main reason is that because these medications are going to eat up your skin, they need to be in a central line. So before you give the chemotherapy, obviously, you're looking at hydration status, you're giving antiemetics, because for sure it's going to make them sick. You've given the medication, you're looking for hypersensitivity reactions, you're assessing for any vesicant precautions, you're looking for extravasation, which is where these medications are basically eating up your tissues, using gloves, you're monitoring the IV site closely. All of that needs to be going on during the administration. Post-administration, you're utilizing interventions for common side effects. And look at your common side effects. They're pretty much systemic. So myelosuppression, infection, bleeding, fatigue, GI complications, anorexia, nausea, vomiting, xerostomia, alopecia, renal system electrolyte imbalances, neurology system, paresthesias, all of that you're looking at. All right, so this is just another slide that is describing chemotherapy agents. They can be called cytotoxic drugs. Extremely irritating to tissue is known as a vesicant, right? So you're monitoring for any of that. So medications that are extremely irritating to tissues are known as vesicants. And then here you're just given different types of meds, different stages that they can interfere with cell replication. They target rapidly growing cells. The bad thing, like I've been talking about over and over again, is that a lot of your epithelial cells are also rapidly growing. So therefore, your chemo is going to attack them as well. So that's why the blood, your hair, GI tract, mucous membranes, reproductive tract, all of those are going to be attacked as well. And it's going to show up. So myelosuppression, this is what's going on. By now you know what that is. Xerostomia, dry mouth, alopecia, loss of hair. So just a whole bunch of different types of manifestations that can happen. So they can be called anti-metabolites, anti-tumor antibiotics, alkylating agents, anti-mitotic agents. Anti-mitotic would be the ones that are targeting the when the cells are proliferating and splitting in half and or in triples or whatever. All right. So, and the goal of chemo is to eradicate as much of the cancer cells as possible, but it doesn't necessarily eliminate all of it, right? And the goal is always that your immune system will be able to kick in and get rid of the rest of them, of the cancer. Extravasation, so it's eating up your tissue, IV site. We don't want that. So that's why we need a just central line. in place, because this is what can happen to your skin. All right. Caregivers may be exposed to low doses of agents via direct contact. So now we're under chemo. So under radiation, we talked about how the nurse needs to protect themselves as well as the family members. So now under chemo, we also need to protect ourselves because we can be exposed via inhalation, contact, or ingestion. So making sure you're adhering to the facility precautions, making sure you have spill kits available as needed, you're following all the rules in terms of giving chemo, and you're maintaining the precautions. And you're going to get extensive training in this if you're working on this floor. What is the most important factor in cancer survival? For sure, it is early detection. What is the definitive tool for diagnosing cancer? For sure, it is biopsy. Priority concern during the administration of chemotherapy, extravasation. Because you're giving chemicals that eat up your skin.